Audible, please?
Yes, sir, you can begin.
Yeah. The screen is seen there?
Yes, sir, you can go full screen and begin.
Full screen. I'll go full screen. Full screen, I should look the top or top?
Yes, sir, that's yes, sir. That down, down, down.
Down.
Yeah.
Yeah.
Yes, sir, you can begin.
Yeah. Good evening, everyone. And thanks to Sriharsha and Sahasra Foundation, Event Foundation for giving me this opportunity with children. I think most of you must be very busy with the family.
Sir, your voice.
Time out. Hello?
Sir, some disturbance from your voice, sir. Can you be little close to the screen, or is there any fan running, sir?
No. Is it okay now?
Okay. Yeah, this is okay.
I will be a bit louder. Is it okay now?
Yes, sir.
Yeah. So thanks everyone for joining the Sunday evening, lovely evening, and for a very good time since morning. So let us start without wasting much time. And imaging of the Paranasal Sinuses, I think most of you are well aware from the first year of postgraduate onwards, you start seeing CT scans. Unlike we, when we have done our post-graduation between 1986 to 89, we never ever had a CT scan, look at the CT scan till our PG time is over. So you guys are so lucky that after finishing my PG, I had a look at the CT scan of the paranasal sinuses. Otherwise, we are accessible only to the X-ray of the paranasal sinuses. Now, today's learning objectives for all postgraduates, its residents and senior residents, and some of the junior consultants is the overall imaging, how we can image the sinus, and also the anterior skull-base lesions, so that we can do a good, calculated, planned surgery without any complication to the patient. So these are the imaging techniques everybody is aware of it, and these are 100-year-old X-ray of the paranasal sinuses, CT scan, and then the MR. MR has been very emerging nowadays for the imaging of sinuses for various lesions will continue in the later part of my presentation. So these are the X-rays, Waters view, Baldwin's view. We had some of these studies when we were postgraduates, but now these X-rays are becoming very obsolete and have no importance whatsoever. Because of the simple reason that it has an overlapping effect. X-ray has got an overlapping effect. However, digital we take, there will be some kind of overlapping effects. And the larger sinuses like ethmoidal three chambers cannot be detected, and you cannot assess the ethmoidal three chamber and also the congenital anomalies. So what all we can assess in X-ray is only larger sinuses only. The smaller sinuses cannot be evaluated, so it has become totally obsolete. Although there's still some little place. Still some people are writing, but for me it has become very obsolete, and they have no value in the today's practice. Then the CT scan of the sinuses has become a gold standard for a sinus evaluation. For a simple reason being, it has an optimal display. It shows an optimal display of the bone, the soft tissues, and the air within the sinuses simultaneously. The simultaneous display has made it as a gold standard for the evaluation of the sinus disease. Even now, it is a gold standard for most of the practicing ENT surgeons. It also displays not only the normal anatomy of the sinuses and anterior skull base, but also some variation within the skull base, and also in the orbit and optic nerve and various intercarotid arteries. So these things will be very well displayed. That's why it has become a gold standard for the sinus evaluation. So most of our choice investigation as an initial investigation of choice for evaluation of the sign of disease is only the CT scan with paranasal sinuses because it pinpoints the site of obstruction, it extends, it shows the extent of pathology and the disease, and sometimes it will screen away the diagnosis. Your diagnostic endoscopy history may not work, but the CT scan will give straight away the diagnosis in case of mucosine, in case of mucosine, and the ostium. So no other modality can give a straight away diagnosis. Then the CT scan will give a surgical approach. Whether I can go only endoscopically and achieve whatever the plan I had in my mind, or should I go externally? So it determines whether you can go endoscopically or external approach, depending upon your expertise in endoscopic surgery or external approach. So overall, it gives a roadmap endoscopically for the approach of the disease, whether it's inflammatory disease or a chemotherapy. What about the treatment as well? Yeah. Now, so this is the, I'm audible, please? Hello?
Yes, yes, sir. Please go ahead, sir.
Well,
Yes, you are audible, sir. You can go ahead.
now, see, this I told you, it gives straight away the diagnosis. Look at this benthic cyst or a fibrous dysplasia involving ethmoid on this side. So, looking at this CT scan, straight away we can come to a diagnosis in the case of benthic and fibrous dysplasia. So, that's the beauty of the CT scan, wherein you can spot a diagnosis immediately, and your diagnostic endoscopy may not give any diagnosis. Now, the CT scan, how to prepare, this is a basic thing that I think every resident should know about it. Before, you cannot send the CT, you cannot order a CT scan as it is when the patient is in the OPD room. So, because in acute rhinitis or allergic condition, so you have to prepare adequately for undergoing a CT scan film. So, the patient preparation is the most important. So one has to give a short course of antibiotic, especially in sinonasal inflammatory disease and a decongestive for at least 3 to 5 days and go for a CT scan, and the disease appears as it should be. Otherwise, in acute condition, acute rhinitis or any allergy, the disease appears more if you send a CT scan in acute case. And preferably, you can spray a steroidal spray half an hour before going in for CT scan in the gantry. Then blow the nose. You ask the patient to blow the nose to remove the blood of mucus so that this blood of mucus can mimic as a polyp. So these are the small things, but they count a lot to assess the pathology in the patient undergoing CT scan. And these are window setting, and those are interested. I think this standard window setting will be the 2000 longitude limits at minus 200 with an adequate display of the soft tissue in the bone. And the slice thickness for viewers, all the viewer colleagues, better to order for a high resolution CT scan, especially the 1 to 2 millimeters, 1 to 2 millimeters, your high resolution CT scan. But previously we used to order for sinonasal inflammatory disease 5 to 6 millimeter cuts, but now that's no more being practiced. For a good assessment of the disease, one should order for a high resolution CT scan within about 1 to 2 millimeter cuts. Then this is a multi-plan, this is my choice of investigation. When ordering a CT scan to a radiologist, must specifically write on the order there's a multi-planar with a 3D reconstruction. So this is a choice of investigation wherein you get the coronary cuts, the axial cuts, and sagittal cuts so that you can assess the disease more precisely. So how to read the CT scan? I think these are all basic things. Right and left should be the written very precisely. Sometimes this may go wrong by the radiology department. You should correct it. And you read the septum and lamina papyracea in all the cuts. The central part, the medial limit, the septum, you read out in all the cuts, take away in all the cuts, you read. And then the lateral limit is the lamina, you read it how the lamina, anatomy of the lamina papyracea looks like. Then read the skull base, what is the type of skull base you are dealing with. And the anterior artery, where is the position of the anterior artery, and how it is, how it comes in your way during surgery. Then read about optic nerve and ICA, intracarotid artery. So these are all the vital structures that we have to read out. After reading the medial boundary and the lateral boundary of the sinus disease, we have to read out these important structures of vital structures. Then define the pathology overall. Overall, you have to define the pathology overall. And especially nowadays, we're coming with the DICOM viewer, where you can actually see with the 3D reconstruction. With the DICOM viewer, the software available on the internet, you can download it and you can read with that and reconstruct yourself in your mind that how to go about doing my endoscopic sinus surgery this way. Pardon me, I'm not able to change the slide. It will take me some time. Yeah. So this is the DICOM viewer 3D reconstruction. This with a navigation, and this navigator tool here with the stage section. The stage section, you can put the stage section on the structure you desire to identify during surgery, and you can actually correlate both the coronal, the axial, and the parasagittal cuts. So you can exactly view where you are. This is the optic nerve, and you can see exactly where you are. And this is the area wherein you can see here, this is the curved optic groove, and you can correlate with this with the 3D reconstruction films with the DICOM software. And again, this is again where you can see this probe is at the entry of the sphenoidal entry and in the posterior.
Sir, can you be a little louder?
Yeah, this is at the posterior ethmoid level. You can see posterior ethmoid level. This is a sphenoid which is already being opened, and this is a where you can see the posterior ethmoid level. This you can correlate in all the 3 cuts. So you are at the entry of the posterior ethmoid. Is it clear now? Fine. Am I audible? Hello?
Sir, little louder, sir. There's some muffled.
Am I audible?
Yes, yes.
Yes. So this is the DICOM software. Once again, I go back. So wherein you can put a probe, a suction state sucker, and then correlate to the different structures. This is the optic nerve, where you can correlate in all the cuts, axial, sagittal, and the coronal. Same thing here, we are putting the probe in the keratooptic recess below, and this is at the posterior ethmoidal level. Now, coming to skull base, defining skull base in the CT scan films. As you are aware, the Kilos types have been very popularized by none other than the Croatian physician. He's a physician, he's a professor of medicine, and from Croatia. In the year 1962, he has defined 3 types of skull base. So type 1 skull base, type 2 skull base, and type 3. Depending upon the depth of, you can see the depth of olfactory fossa or the height of lamina lateralis. If the height of the lamina lateralis is 1 to 3 millimeters, it is type 1 skull base. If the height or depth of olfactory fossa is 4 to 7, it is type 2. And if the depth of olfactory fossa is 8 to 16 millimeters, it is type 3. Normally, if you take the commonness of occurrence in the clinical practice, it is the type 2 which is very, very common and which constitutes about 70% of the random CT scan films. Right? The type 1 is 25% and around 5% is type 3. The type 3 skull base is more dangerous type since the depth of olfactory fossa is much higher and you are more accessible to the skull base. So any pathology which has the type 3 skull base is more vulnerable for injury to the skull base and have a subsequent CSF failure. I'm audible now? Hello?
Yes, sir, you can go ahead.
Yes. So if I'm feeble, you just tell me. So this is the type of, this is a type 3 skull base. This is a boy of, 12 years old boy. Sometime 15 years ago, I operated with a polypoidal disease on the left side with a type 3 skull base. How dangerous it is. Here you have to be very careful, especially you are using a conventional instruments. You are likely to damage the skull base. It's how low it is. How low it is. And if you are not careful, not reading very well, preoperatively, the CT scan, you are liable to injure the skull base and to do subsequent injury to the skull base and CSF area. And coming to frontal sinus pathology, frontal sinus is one of the most variable sinus next to sphenoid sinus, probably in occurrence of the paranasal sinus pathology. And you can see the frontal sinus is unequal. There is a disease, complete opacification in this, and there is an incomplete septation with a partial pathology on the other side. Now you can see this is a frontal sinus with a gutter-like pneumatization going into the frontal lobe here. And herein you can see the far lateral pneumatization going up to the lateral wall of the orbit. You can see. And the pathology here, there is a pathology here, it's very difficult to access endoscopically. If there is a tumor pathology like this, then you have to decide whether you can go endoscopically with the angle telescopes and instrumentation, or you need to open up here by external approach. So this is how you have to decide beforehand depending upon the pneumatization of the frontal sinus. This is again a gutter-like pneumatization here in the frontal sinus. And this appears like a 3 frontal sinuses because this is a pneumatization of the gala here, and there is the frontal sinus on both sides. There is incomplete separations, and appears this is a complete separation. It looks like a 3 frontal sinuses. We don't know whether it is a primary, this sinus is leading to another sinus or an independent sinus. So these are the very difficult. This poses a lot of problem, especially while approaching to this. You need to remove this pathology completely. And I think this film, this is a inferior turbinate, middle turbinate, and this is superior turbinate, right? And what is lateral to superior turbinate is the posterior ethmoids. These are the posterior ethmoids. So what are these things? This is the frontal sinus. So the frontal sinus pneumatization is going posterior, very much posterior to the posterior end of the posterior ethmoidal cells. So the frontal sinus pneumatization sometimes it goes back very far behind the posterior. So this you have to make a note of it. Now, intersinus septal cell. What is intersinus septal cell? Is some people refer this as the third frontal sinus. So you can see here, this is a sinus, and this intersinus frontal cell opens into one of the frontal sinuses. So here you can see it is opening into both the sinuses. So this, some people refer this as third frontal sinus. Now you can see midline frontal cell. So this is a midline frontal cell. This is a frontal cell, which is shown here as a midline frontal cell. Is very difficult, and this midline frontal cell, if it is there, you cannot break this cell going from behind. You have to break this from front. If you go behind and put a curette here, you are liable to injure the skull base. Now, what are the frontal cells? So basically, for a postgraduate to understand the frontal cells, all the cells that are there in the frontal recess are the frontal cells. And Kuhn has divided these frontal cells into 4 different categories: Kuhn 1, 2, 3, and 4. So basically, what is the frontal cell? The frontal cell is one. Here you can see this. The frontal cell is one which is placed above the agarnezy. This is agarnezy cell. Above the agarnezy cell, but below the level of the floor of the frontal sinus. This is type 1. This is type 1. Multiple cells placed above the agarnezy, but below the level of frontal sinus. This is type 2. Multiplicity, type 2. Type 3 is a frontal cell, a cell which is above the agarnezy and extending into the frontal sinus at least 50% of the height of the frontal. Sorry, extending into the frontal sinus, going into the frontal sinus. At least half of it is type 3. And this last one is the type. Can you just remove the screen here? I'm not able to see this. Harsha?
Sir,
Can you take out this? Because I'm not able to see this diagram here.
just close it, sir.
Okay,
I
okay.
we can see what.
This is show the grid view. I'm showing that the closing icon is not there. Show the grid view. One more. Can you take it out for some time? Still, I can't see the diagram completely.
Sir, that I cannot control from here, sir. You have to on the go.
Okay. Yeah. Now I can see here. See, this is the type 4 frontal cell where it is completely isolated in the frontal sinus. So this is rather difficult to tackle this particular cell. So type 1 frontal cell, again for the sake of the postgraduates, I repeat, type 1 is a cell which is above the agarnezy, a single one, below the level of frontal floor of the frontal sinus. Multiple cells above the level of agarnezy, but below the level of floor of the frontal sinus. And type 3 is extending into the frontal sinus. Is type 3 and completely isolated within the frontal sinus. So these are type 4 cells, which are defined by Kuhn. Now these are agar cells. You can see agarnezy cells. They are very, very prominent in almost, it is there in about more than 90% of the CT scans. You can see the agarnezy cells. And this is the lacrimal fossa on both sides. The most anteriormost cuts, you can see the maxillary sinus appearing and then agarnezy cells. And this cell, you can see here, this is a frontal bular cell. And this is blocking the frontal sinus. This is a large agarnezy cell. You can see this is a large agarnezy, and this is with it is merging with the skull base. Is the frontal bular cell. So we need to break the agarnezy cell from behind, and we need to break this particular cell from anterior side. Is it okay? Am I audible?
Yes, sir. You can go ahead. I will interrupt if you are not.
So see, I want the people to understand this is a large agarnezy which is obstructing the frontal outflow and the frontal bular cell which is obstructing. Both of them obstructing. To break this particular cell, you can go from behind, but not the same case with the frontal bular cell. You have to break anteriorly and take out all these cells and the disease and define the skull base so that you can protect the skull base. Nasolacrimal duct is aerated very well, to seen very clear in the axial cuts, and this is the mucus within the nasolacrimal duct. Then this is the abnormalities of uncinate process. So this is a crista galli anomalies, and so this uncinate process, which can be pneumatized, which can be inverted, which can be everted, causing osteometal block. And the crista galli, the pneumatization and the opacification can block the frontal sinus outflow, and we need to break this crista galli cell and clear the frontal sinus outflow tract. Now this is uncinate process pneumatization, you can see, and in the random CT scans you can find very much. Coming to anterior artery, the anterior artery, as everybody is the radiology spirit is referred to as the site of Kennedy's nipple, since they use after David Kennedy from US. And you can see this is the medial ductus and this is the superior oblique. So any indentation, the indentation of the bone, a bony indentation between these two muscles is identified as the anterior artery. The anterior artery can be bare or it can have a mesentery over it. Now, this is the concha of the uncinate process. You can see the concha of the uncinate process along with the concha bullosa, which is blocking. Now, I think everybody is familiar with the concha bullosa and the paradoxical middle turbinate. You can see this blocks the paradoxical turbinates blocking the osteometal complex, and there is an axillary pathology here, and there is a partial thickening in this side of the maxillary sinus. Now, there is a bilobed concha here. You can see middle turbinate has got a bilobed concha. If you want to excise this and create a space for any sinus surgery or osteometal block or anything like that, so you may have to break here and preserving this attachment of the skull base so that this cannot be violated. So you can take out this completely and you can partially open this as well. Then coming to maxillary sinus pathology, the hypoplastic maxillary sinus. So as you are aware, this hypoplastic maxillary sinus is very difficult to tackle endoscopically to find, and is more liable to for the surgeon to enter the orbit. In case of hypoplastic maxillary sinus, you have to be very gentle, and if you can identify this preoperatively in the CT scan, then you can tackle it better. So when you say the hypoplastic maxillary sinus, when the sinus, the medial wall, you can see this is the medial wall of the orbit. The medial wall of orbit comes more medially than the medial wall of the maxillary sinus. It is hypoplastic. Normally, the maxillary sinus is pyramidal in shape. In case of hypoplastic maxillary sinus, it assumes the shape of oval. So it becomes an oval sinus. And the pneumatization, as you can see, this is a hypoplastic maxillary sinus, wherein the medial orbital wall is more medial to the medial wall of the maxillary sinus, right? So here it is oval in shape, and the pneumatization does not extend to the floor of the nose, right? Normally, the pneumatization should extend to the floor of the nasal cavity. But whereas in case of hypoplastic maxillary sinus, the pneumatization does not extend to the floor of the nasal cavity, and also it is the medial wall of orbital wall is placed more medially, so that if you are doing uncinectomy, you are liable to enter the orbit. This is the Septation within the maxillary sinus. This is a peculiar CT scan. You can see the septation here. So if you have a pathology here entirely, so you may think this is the end of the sinus, but you may have to break the sinus to have a complete, to break this septation so that you can have a complete sinus pathology removed. Then HeLa cell is defined as a medial orbital cell, medial orbital wall cell, or it can be sometimes it can be septation from the large bulla. If you have a large bulla, a septation from large bulla can lead to HeLa cell. So it's called medial orbital wall cell or infraorbital cell. So if you take random CT scans, the HeLa cells are found in about 10% of cases. And this is responsible for the maxillary sinus outflow, and you need to remove it completely along with the bulla excision. This is a diseased bulla. So you need to define the bulla completely, the pathology, septations, and extensions. And this is a supraorbital cell. Supraorbital cell, a large supraorbital cell. Whenever large supraorbital cell is present, so you need to remember that you have to be very careful not to injure the orbit, number one. And secondly, when there is a supraorbital cell, the anterethmoid artery in the skull base, it runs posterior, more posteriorly in the skull base, rather than in normal position. So normally what will you see? The anterethmoid artery is very close to the superior attachment of the bulla, wherein in case where the supraorbital cell is present, any on one particular side of the sinus, the anterethmoid artery lies much posterior to the superior attachment of the bulla. Then basal lamella or ground lamella. The ground lamella, basal lamella is the posterior attachment of the middle turbinate. As you can see here, with the case of antroconal polyp. Am I audible? So this is the antroconal polyp you can see here, and this is the middle turbinate, and the middle turbinate, the posteriorly it is attached to the medial orbital wall. And look at this CT scan. The middle turbinate is going posteriorly and ramifying itself into two and getting attached to the medial orbital wall. So the basal lamella or ground lamella, either it can get attached to the posterior wall of the maxillary sinus or the medial orbital wall, right? So most commonly it gets attached to the medial orbital wall, and sometimes it has an attachment to the medial wall of the maxillary sinus. Superior turbinate, may not tell you this is a conchoid in the superior turbinate. And coming to onodi. So everybody is aware of what is onodi cell. And the onodi, if you go back, the onodi himself is an anatomist from Hungary, and he described almost 100 years ago, nearly 100 years ago, he described with the aid of a simple microscope, he described nearly 32 varieties of onodi cells in the cadavers. And this onodi cell, endoscopically, it is again revived and redefined by Stamberger, as he described the onodi cell as 1.5 centimeters beyond the anterior wall of the sphenoid sinus. This cell, which is going behind or beyond the anterior wall of the sphenoid sinus, is termed as onodi cell, at least 1.5 centimeters. Right? So it may be closer to optic nerve, 1.01 millimeters to optic nerve, and it has to extend beyond 1.5 centimeters beyond the anterior wall. This is a description given by the standard. And there is a significantly increase in the Asian population. The onodi incidence has been very high. So some papers are described as 70%, 60%. Overall, it is more than 50% in Asian population. So some describe in some papers, they describe as almost 80% of the cases they are all onodi cells. So overall, in Asian population, compared to Western world, you have a onodi cell occurrence is very much high, as high as 60 to 70%. Then Coming to types of Onodi cell. So the Onodi cells have been described as per the importance of the endoscopic sinus surgeon as indirect Onodi, a direct Onodi. What do you mean by indirect Onodi? The indirect Onodi is a post-ethmoidal cell which ends anterior to the annulus of the zin. You know, annulus of zin wherein the muscles of extraocular muscle they get attached to a ligament, the circular ligament is the annulus of zin, where the intraocular muscles get attached, and any cell which ends anterior to this annulus of zin is described as indirect Onodi, which is not of much importance, surgical importance for us. A direct Onodi. A direct Onodi is one where the posterior ethmoid going beyond the attachment of the annulus of the zin. So it is going behind the annulus of zin is a direct Onodi. And in this direct Onodi, there is a negative, a direct Onodi negative, a direct Onodi positive. So what do you mean by a direct Onodi negative? A negative is one where there is no optic nerve bulge into the ethmoid cavity, posterior ethmoid cavity. If there is a optic nerve bulge into the ethmoid cavity, that is posterior ethmoid cavity, and both the cells are going beyond the annulus of zin. One with a direct onodi negative is no bulge. A direct onodi positive has got an optic nerve bulge, and this is a very risky in case for endoscopic sinus surgeon to injure while doing posterior ethmoidectomy and spironectomy. So one has to identify whether we are dealing with a direct onodi negative or positive. A direct onodi positive is the most important for endoscopic sinus surgeon, especially to avoid injury to the optic nerve. And next, how to identify the onodi cell in the CT scan. In the CT scan, if you find the most important is the coronal cuts. To find a coronal cuts, if you see this is a sphenoid sinus, right, and sphenoid sinus left. If you see a horizontal septation within the sphenoid sinus, at the top of it, this is a onodi cell. Same thing, a horizontal septation in the top of the sphenoid or upper half of the sphenoid, which is a onodi cell. You see here, this is a sphenoid on both sides. This is a right, left. This is the onodi cell in the top. Same thing here. You can see the two onodi cells sitting over the sphenoid sinuses, and this is a visible optic nerve bulge. You can see the optic nerve bulge is very much visible with no bony covering. It's the bare optic nerve is very bare, have a thin covering of the sheath, and this is a decent optic nerve and popping into the posterior ethmoidal cells. You can see here, and these are the two sphenoid sinuses. So this is termed as direct onodi positive. Direct onodi positive. Right? Next. Again, this is, you can see, these are the two direct onodi positive post onodi cells, direct onodi positive, where on the roof you can see the decent optic nerve, and from the lateral wall of the posterior ethmoidal cell, that the direct onodi positive cell, it is optic nerve is popping into it. How vulnerable it is for the injury or endoscopic sinus. Then coming to sphenoid sinus. The sphenoid sinus, as Congdon has described long back, that the sphenoid sinus is a very variable organ, and it has a varied anatomy. It has a completely different type of anatomy. You don't have a typical anatomy. It is the most variable organ as far as the anatomy is concerned, and the variations are very common. So depending upon for endoscopic sinus surgeon, the importance, surgical importance is how much pneumatization it has, so that we can approach endoscopically the sphenoid sinus and come out with a complication-free sphenoid sinus surgery. So depending upon the pneumatization, the sphenoid sinus is divided into three categories. There is a concal type, which is only 5%, and the pre-cellar type, which is 28% overall incidence, and the cellular and post-cellular type is the most common, up to 67%. So this is a frontal, pre-cellular, cellular and post-cellular. This is a very common. So the more pneumatization of the sphenoid sinus, the more structures are bare in the sphenoid sinus. So that will come in the next cuts. Now you can see this is the rostrum of the sphenoid where it got pneumatized. These are the two cells, prostate nodal cells. This is the rostrum is coming, and beyond after the rostrum you can get into sphenoid sinus. These are pneumatization of the rostrum. Now you can see these are the black lines. This is the ostium of the sphenoid sinus, sphenoid ostium, and this is the rostrum. Now this is a sphenoid where the intersphenoid septum, you can see it is going up and getting attached to the area where there is a carotid artery. So when this condition is there, so you need to tackle with this intersphenoid septum with either through-cut instruments or with a gentle through. You can't use a blunt instrument to break this. You need to use bit by bit the through-cut instrument so that this cannot be severed and cause injury to the ICA. Now you can see the highly pneumatized sphenoid where all the structures are bare. So you can see these are the two optic nerves which are popping into the roof of the sphenoid, and this is a V2 maxillary and this is a V median. So you have the lateral recess here, lateral recess of the sphenoid. This is a V2 and the V median. The more pneumatization of the sphenoid, the more structures are bare and they are vulnerable to injury. So we should realize, unlike the CT scan of the temporal bone, wherein you have more pneumatization of the temporal bone, more desirable, but not in case of sphenoid sinus. Because if you have a more pneumatization, you have more structures that are there, you should be very careful. And this is the lateral recess of the sphenoid. The lateral recess usually gets formed when there is a pneumatization of the pterygoid. When the pterygoid gets pneumatized, then you will find the lateral recess here. So this lateral recess of the sphenoid is very difficult to approach, and whenever there is any lesion in this lateral recess, especially in case where the CSF linked in the lateral recess and in and around the vicinity of V2, you may have to drill this area, the pterygoid, and completely do a pterygoidectomy, and then go with the complete exposure of this lateral recess and the V2 area and the median and do your job adequately. Now this is again intersphenoid septum, you can see. So there is an incomplete septation here, and this septum is going and getting attached to the carotid artery. Here is the carotid artery, it sides here, and getting attached to the carotid artery. So I think we need to deal gently with this kind of intersphenoid septum. Then again, this is a very far lateral pneumatization of the sphenoid, going beyond the the lesser wing of the sphenoid and greater wing and lesser wing of the sphenoid, going far lateral pneumatization. And if you have any pathology, you need to tackle with an angle telescope from here, and this angulation needs angular instruments, and you need a lot of endoscopic expertise to tackle any pathology very laterally. Now coming to the cone beam CT scan, I think as a postgraduate you need to know what is cone beam CT scan. But in ask you, this is a very compact version and a very safe and faster version of the CT scan with the 3D images. And the cone beam CT is already there, available in many places, and it gives a very less radiation compared to the routine normal CT scan. So almost the radiation exposure is 100 than the regular CT. So I think the best for if somebody needs a CT scan for very regular intervals and follow up, is the best. And it takes less than a minute to get images. as many images, 125 images or 220 images, something like that. Then coming to other modalities of the imaging of the cities, imaging of the paranasal sinuses is another. The MRI of late is coming with a lot of innovations, and because there is a MRI is coming to of late, the importance of MRI has been getting increased day by day in the imaging of the paranasal sinuses, especially in tumor pathology and other sinonasal inflammatory pathologies. So, the basic reason why the MRI has taken a deep root in the evaluation of the sinus disease and management of sinus disease for a better outcomes postoperatively is that the advantage of MRI is it can give a sequences of more than 1,000 or 1,200 sequential images, sometimes fat surprise, not surprise, and then different kind of soft tissue images. So the sequences are many. You can get 500 sequences, 1,000 sequences, depending upon your requirement and the ability of the radiologist can give such images. So the MRI for us as a basic for a residents, so when to take MRI for a sinus evaluation or a skull base evaluation. So especially if you have a diagnostic dilemma, with a CT scan, I think you can think of MRI and discuss with the radiologist. So how best MRI can help in case of those there is a diagnostic dilemma with the CT scan. Then diseases going beyond the sinuses. For example, if the disease is there in the orbit or eroding the skull base, I think MRI will come into picture. Then all sinonasal tumors. The sinonasal tumors, no doubt MRI will give a lot of information with regard to the extension of the orbit or a skull base or a muscles involvement or the deep rooted in the deep crevices of the sinuses. So this is immense importance. And all the immune compromised hosts, I think no doubt MRI will give a lot of information, especially in the invasive sinus disease, invasive sinus inflammatory disease. And post-op complications. When you have a post-op complication involving orbit and optic nerve and the skull base insult, then probably MRI will come into picture. So these are some of the overall indications wherein you can think of the MRI can have an edge or it can give a complementary role. It can give a complementary, more additional information compared to CT scan. So the CT scan is the basic investigation for us. But MRI, these are the indications where the MRI can have a definite role to complement your CT scan for arriving at a particular diagnosis in the pathology and give an exact roadmap and the plan for the treatment. Then coming to one of common situations in practice. So what are the situations we get in clinical practice, in a day-to-day practice? So we'll go from basic thing to a very invasive sinusitis, where the CT scan, how it appears, what is the role of CT scan in case of certain common situations we encounter in our practice, and how the MRI can give information for additional information so that it can play a definite role in the diagnosis. So to start with the anthropoid polyp. Am I audible, please? Hello? Am I audible? Hello?
Yes, sir. You can go
Okay.
ahead, sir.
Yeah. So first, initially, the anthropoid polyp is a very, very common thing, and all the residents will know that is how to diagnose an anthropoid polyp and how it looks in the CT scan. The CT scan versus MRI in different pathologies. That's what our discussion is now. So for anthropoid polyp, the preferred method of diagnosis is the CT scan. So you can go for a plain CT scan. A plain CT scan because there is no advantage because plain CT scan will be adequate for the precise diagnosis of anthropoid polyp. How it shows? It shows as a smooth, you can see, homogeneous, smooth enlargement with little lobulations here and there, right? And with a wide posterior frontal. Accessory osteum is very wide, with smooth enlargement, no bone destruction. The bone is absolutely clear all around. Soft, lobulated, homogeneous opacity with a clear bony outline, no destruction, usually gives a diagnosis of anteponic body. So if you take MRI, the T1 weighted image gives low or intermediate signal and T2 will give a high homogeneous signal. But for a routine, if you can take the CT scan, has this kind of appearance, there is no need for going MRI. In case of doubt, if you have a doubt, then certainly you can go in for the MRI and look for the T1 weighted image and T2 weighted image. Inverted papilloma. The classical appearance of inverted papilloma, these are the plain films. These are not contrast films. These are the plain films. Plain CT scan. You can see the CT scan bone windows and all. So the typical appearance of inverted papilloma on the CT scan is a ballooning opacity. You can see the ballooned out opacity. Ballooned out opacity lesion with hyperostosis. The area is hyperostosis. These hyperostotic areas will give a clear-cut diagnosis of the inverted papilloma. Now, if you go for MRI, so if you are in doubt, if this picture is very clear, then straight away it gives the diagnosis of inverted papilloma. There is no need for going MRI. Need for going for MRI. These hyperostotic areas can be there in the ethmoid, can be there in the frontal sinus, or can be there in the maxillary sinus. I have seen the cases with the maxillary sinus, inverted papilloma, with the hyperostosis, frontal sinus, and ethmoid. All are described. If such a picture is there, with a plain CT scan, it is enough for diagnosis. If you are in a diagnostic dilemma wherein you can't say there is no hyperostotic areas and there is no clear-cut ballooning opacities, then you can go for the contrast MRI. So these are the contrast MRI picture from maxillary sinus, where you can see typically a T1 weighted image and T2 weighted image, which show very characteristic convoluted cribriform pattern. This is called CCP, convoluted cribriform pattern, which is described as radiologically as alternative bands of hypo and hyper wave shadows. You can see the hyper waves and hypo waves. So this is very typical appearance of the CCP, that is convoluted cribriform pattern of inverted papilloma. And if you have a loss, and also you can see if the convolution pattern is starting from here, and this is attachment. You start from here, this is attachment. So you can know the diagnosis of CCP, the inverted papilloma diagnosis by CCP, and also you can see the attachment wherein. So if you start these convolutions here, from here and spreading convolutions, where the starting point is, this attachment. And also, if there is loss of CCP somewhere in the middle or in the beginning, a completely area of the loss of CCP, that is convoluted cribriform pattern, then there you have to suspect malignancy. As you all know, the inverted papilloma is a pre-malignant condition. If there is a loss of CCP in certain areas, then you have to suspect the malignancy in those cases. Now, allergic fungal rhinosinusitis is again a very common clinical condition, wherein you can see a plain CT scan of the paranasal sinuses may not give a straightaway diagnosis of allergic fungal rhinosinusitis. But a contrast one, you can see this is a contrast CT scan of the allergic fungal rhinosinusitis. This gives a very clear picture of heterogeneity, wherein these are heterogeneous areas, these are hyperdense areas and hypodense areas. The hyperdense areas are due to the calcium and magnesium salts. calcium and magnesium salts. It gives a hyperintense areas and hypodense areas by the diversification. So if you take MRI, again MRI again a very characteristic compared to the CT scan contrast. If you take MRI, but this case, the same case MRI is taken, you see these hyperintense areas due to calcium and magnesium salts, hyperintense areas, they completely disappear. This is called hypodense, it becomes a hypodense or a signal void, no signal. It is very typical of allergic fungal anaphylaxis. So if you have a diagnostic dilemma with a CT contrast, then you can go for MRI to prove the diagnosis. If there is signal void, certainly I give the diagnosis of allergic fungal rhinosinusitis. So coming back again, for the sake of postgraduates, allergic fungal rhinosinusitis, the plain CT scan has a limited role. You have to go for CT contrast wherever possible, which gives a diagnosis in most of the cases. If you are still in a dilemma, sometimes it happens in the clinical practice, then you can go for MR. That MR shows the signal void areas or hypointense areas. And that gives a clear-cut idea that I am dealing with the allergic fungal rhinosinusitis. Next is the mucocele. The mucocele, I think the best way to diagnose the mucocele is the CT scan. The CT scan is the best way to diagnose. It gives a circumscribed opacity with a bony expansion. There is a bony expansion, no destruction, a bony expansion into the orbit, into the frontal sinus, into the nasal cavity, and so on. If it is going into sphenoid sinus, yes, it is expansor lesion. It is expansor lesion with a bone, no bone destruction, and the thinning of the periphery. So this is a clear-cut diagnosis in the CT scan. The MRI has a limited value in case of mucocele because it is a variable. So depending upon the water content and the protein content, the MRI picture varies. The T1 and T2 weighted images are so confusing because it depends on what is the water content and what is the protein content. If you have a protein content more, then it is more significant the T2 weighted image. If you have water content more, the T1 weighted image is more important. Not able to change it, taking some time. Yeah. What is about mucocele? So, coming, we have covered with the entrepreneurial polyp, the inverted papilloma MRI, allergic fungal rhinosinusitis, mucocele, and CSF rhinorrhea. So, in case of CSF rhinorrhea, what are our imaging modalities and imaging techniques that one can apply for a precise diagnosis of CSF rhinorrhea? So, the imaging modalities that are being followed worldwide is the CT cysternography, the high resolution CT scan, the MR cysternography, the radionucleotide, which is very rarely done, and the gadolinium enhanced cystogram, yes, it is done in certain centers. The fluorescent dye, yes, it is done not in India very regularly because in India it is banned, but other Western countries, the fluorescent dye test is done. Then coming to what is my choice of investigation. Usually our choice of investigation is if you take out the non-invasive technique, the high resolution CT scan 0.5 to 1 millimeter cuts is the initial choice, right? And the CT cysternography is the really gold standard for many centers, but its limitation is you get the leak in the images only when the leak is active. And same with the MR cysternography. This is a non-invasive. The high resolution CT scan is a HRCT 0.5 to 1 millimeter cuts is a non-invasive. MR cysternography is a non-invasive. The CT cystonogram is an invasive where you have to do lumbar puncture and do that. So this is not without complication. there may be some complications associated, like fecal meningitis and all those things. And same thing with the gadolinium enhanced cystomegram. The advantage of gadolinium enhanced cystomegram is it stays in the CSF space for more than 18 hours, or sometimes 24 hours, and you can take the number of films at the regular intervals to show the CT scan. But again, this is an invasive procedure and not without any complication. It was a complication of the epilepsy and then the fecal meningitis and all. So overall, if you look at the battery of investigation, fluorescentitis, of course, in the difficult cases, out in, not permissible in India, but it is there in the Western countries, and it's a very highly sensitive test. And this also is useful only when there is a leak, active leak. So high resolution CT scan means by bony defect you can identify. So overall, I think so many are there. To just brief you, if for active leads, CT cystomegram and MRI cystomegram, especially T2 weighted image, is my choice of investigation. So this is a non-invasive. Again, this gives a bony defect. Radionucleotide is not done. And gadolinium, some centers do it, but this is again with complication with meningitis and all. Now, showing some pictures of my own cases, you can see this is a CT cystomegram where you can see the dye here, there is a ethmoidal link here, and the contrast is trickling here into the ethmoid cavity. This is a plain CT scan, a plain CT scan in a boy of 9-year-old, and you can see the active CSF leak with a meningoencephalocele from the cribriform plate and the adjoining. So these are huge defects. It's about 1.5 to 2 centimeters defect. It's a plain CT. Now this is a MRI with a T2 weighted image. The CSF gives high signal in the T2 weighted image, wherein if there is an active leak, certainly it picks up. The MR has an advantage of not only diagnosing CSF leak, but also it can identify the raised intracranial pressure, and second, you can rule out the intracranial lesion like a tumor. The advantage of the MR is basically it is a non-invasive. It gives a high signal intensity of T2 weighted image. It not only gives the diagnosis of CT scan by T2 weighted image of appearance of CSF as a high intensity signal, but it also gives the certain signs of raised ICP, raised intracranial pressure, and rules out the tumors, intracranial tumors. So, how to identify the raised intracranial pressure in MRI? It gives the clear picture of dilatation of optic nerves and sheath with a tortuosity, slit-like ventricles, and a vertical buckling of the optic nerves, and empty sella with a hydrocephalus, and globe flattening and optic atrophy. There are so many signs in the MRI. So MRI is certainly an investigation which one must think we have to, is a mandatory investigation along with the CT scan, because we don't know which case has got a raised ICP, raised intracranial signs, and which case has got tumor intracranially. So one has to take MRI as a mandatory in all cases of CSF, unless it is only a small traumatic leak, following injury, that's a different story. But in case of the CSF leaks for longer time, I think MRI is always complementary to the high resolution CT scan or a CT contrast. And this is a child with a CSF rhinorrhea with a meningoencephalocele. Is a 11-month-old baby. It's a congenital defect here, and a huge encephalocele here. Is a MR picture. It gives such a beautiful picture, and this has been operated almost 10 years back for me. The child is doing very good. Now he's a 10-year-old. He's going to school. Now this is a traumatic CSF lead, where you can see the head trauma with a hit with a frontal bone here, with a rod, with a iron rod, and if you sustain injury here, there is a herniation of the brain here with a CSF. There is a inner table fracture, outer table fracture, and a picture like this is the CSF Rhinology CT. All traumatic CSF leads, is a CT scan, which is a gold standard. You can do MR to exclude certain other things like a parenchymal injury of the brain, or a hematoma, or a subdural hematoma, extradural hematoma, etc., etc. But to define the fracture and the CSF lead and any herniation into the fracture segment, then CT scan is the gold standard as an initial choice investigation in case of traumatic CSF lead. JNA, coming to JNA. So in JNA, the contrasting CT scan is the choice investigation. The first and most foremost investigation one has to order is CT scan contrast. Is a choice investigation. It gives not only the diagnosis but also extent and where is the site of origin. What is the site of origin? What is the extent? And the typical pattern of the DNA can be delineated in the CT contrast. And MR angio have got a lot of importance of late. The MR and MR angio can accurately assess the extension of the tumor, whether it is going intracranially and eroding the orbit, or it can go intracranially, eroding the skull base and dura, or intraorbitally. And depending on soft tissue invasion, it can also be delineated with the MR and MR angio. So the exact extent of the tumor can be given by MR, and which is useful for staging of the JNA. The staging of JNA should be done with the contrastivity as well as the MR. The MR angio of late is assuming more importance to assess the tumor vascularity and its branches, the sphenoparietal artery, the intermedullary artery, the ascending pharyngeal artery, or any other arteries, as is occipital artery. All these things can be delineated in the MR angio. And where this where this vessel is going into the tumor to supply the tumor, it is going from behind or laterally or anteriorly. The anterior entry or posterior entry or a lateral entry will be clearly demonstrated in the MR angio, so that we can go and first tackle that particular area, to clip the artery there, cauterize the artery there, and proceed with the rest of the dissection. So this has been very, very important of late, and people are doing MR angio as a mandatory investigation in case the JNA, which is very large and very huge proportion, and because it threatens the bleeding. So what is there in the JNA surgery is the bleeding, and the bleeding have to be tackled initially only before getting onto the dissection of the JNA. Then DSA, the distracting angiography, subtractive angiography, is to identify the feeding vessels and the embolization. The feeding vessels can be clearly delineated and then go for embolization if necessary. If necessary, if you feel that the JNA has to undergo embolization, you may have to do digital subtraction angiography against. And 3D CT angio again is like the same MR angio, 3D CT angio. You can see this is a contrast CT scan. The contrast CT scan, you can see this is the widening of the sphenoparietal foramen in the lesion here, extending into the sphenoid sinus and occupying completely the corona and the sphenoid sinus. These are sphenoparietal foramen area where it is very much widening by the tumor. This is a contrast CT scan. This is a choice investigation. Again, a contrast investigation in case of, see, you can see the contrast, that's a clear dumbbell-shaped tumor at the JNA. So this is in the choana, this is the posterior septum, choana, the sphenoparietal area and the peripheral area. Sphenoparietal foramen area and the peripheral area, and going little bit into the second focus. So we can see the homogeneous enhancement of JNA, such a clear picture of homogeneous enhancement and bundle shape in the axial picture contrast. Again, a contrast picture, you can see the same thing, axial city contrast of JNA. Then the JNA, how it gives, what is the advantage of the MR in dealing with the JNA is the MRI differentiate the tumor from other soft tissue retained, other soft tissues, because a JNA can appear very big on the CT scan, and sometimes the contrast also will give very good, very big picture. But if you take MR, so it can give clear extent of the tumor, especially differentiating the soft tissues and retained secretions. The tumor appears smaller compared to the CT scan or CT contrast. So it gives an accurate staging, the MR, along with the CT scan for a JNA. Then accurate tumor staging, it works. Then intracranial extension, cavernous sinus involvement, orbital involvement, whenever they are there, the MRI is very, very useful, especially to delineate the extension, whether you are dealing with it, whether going subdurally or extradurally, and hope for the involvement of cavernous sinus in orbit. So there, the MRI will give a very clear picture. The medullary bone involvement of pterygoid wedge. The pterygoid involvement, especially the medullary bone, it cannot be delineated using the CT contrast for a JNA evaluation. The MR is the only one which can give very clear picture of pterygoid wedge involvement, because the most typical site of origin of JNA is a pterygoid wedge, and sometimes the base is sphenoid and the sphenoid bone itself. So when the pterygoid marrow is involved, you are likely to miss that particular thing, and you just exercise it, leaving out the pterygoid wedge like that. When there is a marrow involvement, you need to drill out the pterygoid completely and take out the complete body of the pterygoid should be completely taken away so that you can prevent the recurrences. So there lies the importance of MR in managing JNA. Now you can see the axial MRI, the T1-weighted image. This is MR in JNA. You can see these are the small black ovoid areas. They are called signal void areas. So these represent the vessels. The more signal void areas, the more vascularity of the JNA. These are enlarged vessels. Then this is the coronal MRI T1 with the contrast. You can see the multiple flowoid areas. These are flowoid areas. Dark dots, rounded dots, semicircular. So these are the flowoid areas. This is embolization of JNA, where there is a tumor blush. Before embolization, you can see the tumor blush, and this is a complete disappearance after embolization. Now, this is a digital X-ray taken sometime about 10 or 15 years ago. This is a JNA tumor blush. Tumor blush, contrast, injected tumor blush, you can see. This is a disappearance of tumor blush after embolization in the gel form. Then coming to invasive fungal sinusitis. Invasive fungal sinusitis, you have acute invasive fungal sinusitis, which is a fulminant variety, which is a very dangerous variety with a lot of intracranial complications. This can occur in diabetics or immune compromised. Even diabetics, then the rhizopus and mucar are more common. Immune compromised aspergillus is common in about 80% of cases. And chronic invasive sinusitis, the diabetics are more common. And mucar, rhizopus, aspergillus, those are the three culprits which can afflict in diabetics, leading to chronic invasive sinusitis. It's a very indolent nature, very chronic course, less dangerous compared to fulminant variety acute invasive fungal sinusitis. Sometimes the chronic invasive can occur in immune competent host. So this of late we have seen quite a good number of cases where the immune competent patient, non-diabetics, this can present like a tumor-like presentation. It presents as a facial swelling, or swelling in the orbit, swelling in the maxilla, or swelling over the face, like a tumor-like presentation. Very hard tumor-like presentation It will give a lot of diagnostic dilemma. Especially if you do a biopsy, it's very difficult to establish a diagnosis sometimes in these cases. So acute invasive fungal sinusitis. So this is a CT scan picture. You can see the bony details here. And here there is a ethmoidal involvement with the nasal cavity, ethmoidal, going up to the post-ethmoid, going up to the sphenoid cell, and unilateral ethmoid involvement with the bone destruction. And there is an intraorbital stage. You can see the lamina is gone here. The lamina here opposite side. The lamina is gone here. There is an intraorbital extension. And with the proptosis, you can see the proptosis here. So this is acute invasive fungal sinusitis. The CT contrast. This is a CT contrast picture. Now, acute invasive sinusitis is MR. How MR looks like? The MR looks like the involving sphenoid sinus, the thrombosis. You can see this MR picture will give a very indolent nature. And there is the areas, there is a sphenoid sinus involvement, more of the signal wide areas, and infections, multiple infections are there. So it's a chronic invasive fungal sinusitis. Chronic invasive fungal sinusitis. This is a non-diabetic person, even non-diabetic. He presented with the swelling, facial swelling here. So we have gone through endoscopically, opened up this area, and then taken out this tumor-like thing, occupying the medullary sinus. So actually we had external biopsy, but that has yielded nothing into the going into the orbit. So we have done endoscopically, opened the orbit and removed a bit of this endoscopically as a second attempt, following the Rational approach, and this is ruled as chronic fungal sinusitis, invasive fungal sinusitis. There is a CT scan of the same patient. You can see it's going into orbit. So hyperattenuated in the CT scan, what you see is a hyperattenuated soft tissue mass-like lesion with a bone destruction. You can see the bone destruction here, soft tissue mass-like lesion. You think as if it is a tumor, but it is a chronic invasive fungal sinusitis. This is actually caused by rhizotus. MR, to take MR, the signal wide or low intensity signal in both T1 and T2. In chronic invasive fungal sinusitis, if you take MR, you have a signal wide or low intensity in both T1 as well as T2. That's a very characteristic feature in case of chronic invasive fungal sinusitis. So this is again a chronic invasive. The CT scan and MR, you can see very clearly here what is the difference. So in a chronic invasive fungal sinusitis, which is of indolent nature, tumor-like condition, so you can see this is a frontal sinus lesion here. So hyperintense shadows, homogeneous hyperintense shadows, and it can be completely signal wide or low intensity in MRI. So this is rather pathognomonic of chronic invasive fungal sinusitis, CT versus MR. Now coming to fibrous dysplasia of the nose and paranasal sinuses and the facial bones. Is you can see here the sphenoid sinus, fibrous dysplasia, the pterygoid ridge, so the infratemporal fossa, pterygoid, the infratemporal fossa, pterygopalatine fossa, pterygoids, and sphenoid. So it's a huge fibrous dysplasia. The choice investigation in these kind of lesions, fibrous dysplasia, is a CT scan. Again, this is a fibrous dysplasia of the ethmoid. You can see a boy with a hypotonia going into the orbit. The CT scan is a choice investigation. MR have a very limited role. In these kind of lesions, MR has a limited role. Then osteoma of the frontal sinus is a choice investigation with a CT scan. You can see osteoma of the frontal sinus. Thank you very much for your attention.
Thank you, sir. That was a really great extensive lecture on imaging, sir.
Any
Sir,
questions?
yes, sir. A lot of questions, sir, but Dr. Munka, sir, wants to speak, so I'll unmute him.
Okay, no problem. Munkaji, good evening, sir.
He's,
He's not in the mic.
I'm unmuting him.
Yeah. Good
Yes.
evening, Dr. Venkatram.
Yes, sir. Good evening, sir. How are you, sir?
Oh, fine. Thank you. Happy New Year to all of you.
Oh, thank you, sir.
I was listening to you. It's an excellent lecture. You have covered most of the conditions and your collection is superb.
Thank you, sir.
Some of the points, since our audience is postgraduates, and I find still many of the practitioners of say last 20 years experience, many people don't know how to fill a proper requisition for CT-MR. So unless and until we tell the radiologist what we are expecting and what we want. So I wanted your opinion on how to put a requisition for CT-MRI, number one. Number two, for the CT, should you ask for a soft tissue window or a bone window or leave it to the radiologist? Probably we will like to say that we want a soft tissue or a bone window. And whether contrast or plain, again, we know most of the conditions. So that should be very clearly mentioned in the requisition. This was about CT. About MR, T1, T2 images people talk about, but many of the postgraduates still have doubt. What is T1, what is T2? You have shown in most of the conditions the T1 images, T2 images. So that requisition also you should put to your radiologist, or you should depend on his prerogative whether he takes it. So these are few things I will like you to clarify and give your comment.
Sir, regarding CT scan for sinonasal inflammation regions, most of the situations for inflammations confined to only paranasal sinuses with a limited pathology, the high resolution CT scan is enough. You don't have to go for contrast.
Yes.
But tumor-like conditions or tumor-like condition, for example, fungal sinusitis is a tumor-like condition. Or tumors, all benign tumors, all suspected malignant tumors. You have to go for contrast.
Yes.
And if necessary, you can ask the radiologist oblique MR in place where there is required. If the tumor pathology is there, obviously you have to go for MR. In case of CSF rhinorrhea, you have to write clearly the diagnosis of CSF rhinorrhea and place your requisition as whether you need only a resolution CT scan or a CT contrast, or you want a blow-up pictures. So you have to specify what you want.
Yes. Because most of the people till now, I see the requisitions, they hardly mention, what basically they are suspecting and what images they want.
They write a diagnosis, but what we need, different sequences of even MR also, and certain things you have to leave it to radiologist, and for that matter, you have to speak to the radiologist. What are the things you want from your point of view as a surgeon, and what are the things that radiologist is looking at it to give a precise diagnosis?
Right.
So that has to be clarified.
Best practice is,
and most of us are usually they shy away from speaking to radiologists.
Yes. No, so the message to all the postgraduates, you should write a proper requisition mentioning the diagnosis and giving a choice to the radiologist.
Even for sinonasal inflammatory CT scan PNS is not sufficient. HRCT is not sufficient. Multiplanar HRCT.
Yeah. So that should be very clear. And as you said very correctly, we all should develop a habit of sitting with the radiologist on their monitor and discuss. At least once in a while, one must sit with them.
Yes.
You agree with me?
It is better to devise a referral slip containing different varieties of radiological requisitions.
Yes, that is yeah.
Yes.
I think that is Dr. Harsha, if you can get such sort of slips, the requisition for CT, MRI, as Dr. Reddy has said very correctly, this will go a long way for the PGs as well as the practitioners.
Yes, sir.
So, yes.
Thank you very much. Yeah, excellent.
Good evening, Venkatram.
Any questions? Anand.
Good evening, Venkatram.
Good evening, boss.
Congratulations for a very lucid, elaborate, and well collection of all the CT scan and MRI.
Thank you, thank you.
That
Nothing new for you, but I'm very happy that you are there in the line.
you have given a very clear understanding to the postgraduates.
Yes, I've gone only through the PG point of view because it's a PG online teaching.
Yeah, it was still very elaborate. Congratulations once again.
Thank you so much.
Sir, how do you differentiate anterior ethmoidal
I want to ask questions from the PGs, please.
How do you differentiate anterior ethmoidal cells from posterior cells in a CT-PNS?
Anterior ethmoidal cells from posterior ethmoidal cells. Basically, to see first in the CT scan, you study a cellular pattern. The first cell that you come across is the agar cell, right? Lateral to the agar-Neji cells, you find the lacrimal fossa. And if you go a little behind, then starts the bulla, that is antiethmoid. The antiethmoid cells are multiple, varying from 1 to 7. That you have to, you cannot count the cells in case where there is a pathology, polypoidal pathology. But in case where pathology is not there on the other side, you can really go across, and the sinus anatomy vary from right nose to left nose, very different. So the anti-ethmoidal cells are a bit smaller compared to post-ethmoidal cells. Then if you break the bulla and completely remove the bulla, you find the basal lamella or ground lamella, which has to be identified very clearly in the CT scan. Now, what is behind the ground lamella is the sinus lateralis, and then the post-ethmoid starts. The post-ethmoidal cells are usually larger compared to anti-ethmoidal cells. And what are the cells that are lateral to the superior turbinate? Radiologically, they are post-ethmoidal cells. The cells which are lateral to the middle turbinate are the anti-ethmoidal cells. But if you go behind, identify the superior turbinate, eye up. What are the cells which are lateral to the superior turbinate or the post-ethmoidal cells? Then, most important in the identifying the post-ethmoidal cells is the identification of ONOD cells, which I covered very elaborately. What is ONOD? What are the different types? Direct, indirect, direct negative, direct positive. So these are the things a postgraduate should analyze in their initial readings. If any doubt, they can approach their faculty and discuss.
Sir, how do you identify coronal atresia on CT scan?
Coronal atresia CT scan is very usually coronal atresia. If you just follow the septum, follow the lateral wall. Somewhere at this point, there cannot be any continuation of the nasal airway. The nasal airway is shut off between the septum and the lateral wall. Somewhere. So it may be very thin membranous, the membranous atresia. It may be a thick bony, which can be detected in the CT scan. CT scan is a gold standard for the coronal atresia. So you can see the bony line which is shutting off the nasal airway between the septum and lateral wall is the coronal atresia.
What is double turbinate?
Pardon? Double turbinate. Double middle turbinate. Hello?
So there's a question meaning what? Dr. Saket, can you unmute and directly ask the question?
Yes.
I request the PGs to unmute themselves and ask the questions directly. That
Some
would be
cannot unmute. Or you can go to chat box, no? Is there any chat box, Dr. Harsh?
Sir,
Yes, sir. They are unable.
good evening, sir. Hello,
No, if you have chat box 1, 2, 3, 4, 5, I can answer very quickly.
hello.
Yes?
Good evening, sir.
You are audible.
Yes, sir. Double middle turbinate I'm asking, yes, sir.
Double middle turbinate is the name given for enfolding of the uncinate and then middle turbinate. So see, uncinate appears as the turbinate, middle turbinate. See, the uncinate can be folded. Actually, the middle turbinate very clearly seen as in a diagnostic and nasal endoscopy. And in the CT scan, it appears as a very bulky. Radiologically, the uncinate will appear as a bulky, not a very clear soft tissue lining like this, projected structure from the elevated structure from the upper part of the inferior turbinate. It's not like that. It's a soft tissue folded like structure and very clearly seen, very clearly identified in the diagnostic endoscopy, where it gives appearance of a middle turbinate.
Okay, sir. Thank you, sir.
Sir, I think we can conclude for the day, sir, because it's almost 9:10. So,
Right.
no more questions from the PGs. Thank you once again, sir. It was a very enlightening lecture. And we have covered every aspect of PNS and we have covered most common diseases. I think, PGs must had a very long take-home messages for the day. Thank you, sir, once again. And we'll be having one more lecture by sir on the CSF rhinorrhea on next month, around February 28th. So we'll see you again, sir. Thank you.
Well, thank you.
Once again.
And ENT, Sahasra ENT Foundation. Thank you.
Thank you, sir. Good night, sir.